Yes, a very good evening, boys and girls. So we are again with a revision of the FMG session in physiology. I'm your mentor, Dr. Reena. So what we'll be doing is we'll be taking MCQs, and with MCQs we will be trying to discuss the theory that is related to it. And I really wish that the session will be really helpful to you, and you can come up with the doubts, right? अगर कुछ भी doubts है तो you can just come up with them. So can we start? Everybody, am I audible, visible? Yes. So good evening. Yes, Rishi Raj is there. Good evening. Let's get started. Now, which of the following substance is true regarding the tone of the lower esophageal sphincter? Right? Which of the following substance is true regarding the tone of the lower esophageal sphincter? Good evening, Rimi. Good evening, beta. God bless you all, and let's get started. Yes, come up with the answer, Rimil and Rishi. Anybody there who can come up with the answer? Decrease substance P in the lower esophageal sphincter, increase in the acetylcholine, increase in the nitric oxide, or absence of the Meissner's plexus in the lower esophageal sphincter. So which of the substance is responsible for regarding maintenance of tone in the lower esophageal sphincter? Anybody can come up with the correct answer? किसको समझ में आ रहा है? Yes. So the correct answer over here is B. Right? The correct answer over here is B. That is increase in the tone in the acetylcholine in the lower esophageal sphincter. Now let's try to understand this. So when you speak of the smooth muscles of GIT, they are going to show movements which will be tonic, and they are going to show movements which will be phasic. ठीक है, tonic movements and phasic movements. These tonic movements are mainly at the level of the sphincters, right? So they are responsible to maintain the tone of the sphincter. You know that if the tone of the sphincter is not maintained, there is going to be regurgitation of the contents, which we don't want. And the phasic movements, which are the digestive movements, which could be your peristalsis, or which could be the propagative movements. So there are important neurotransmitters to be considered in GIT. These important neurotransmitters are VIP, that is vasoactive intestinal polypeptide, and nitric oxide. These two are responsible for relaxation. So whenever you have to bring about the relaxation, whether it is peristaltic reflex or whether you want to propagate, whenever you want to bring about the relaxation of a particular segment of the GIT, the neurotransmitters are VIP and nitric oxide. But when you have to bring about contraction, right, or conditions which are going to increase the tone, at that time the important ones are going to be your substance P, and they are going to be acetylcholine. And when food causes stretch, ठीक है, when the bolus of the food, it causes stretch, this stretch is going to bring about the release of serotonin from the enteric nervous system. This serotonin will then act upon the serotonin coming from the sensory nerves will then act to bring about the local peristaltic reflexes. And you know that what is the reflex? It is like this. What is this? This is your food bolus. This is your food bolus. So this food bolus is going to cause the contraction of the segment which is behind, that is by substance P and acetylcholine, and relaxation of the segment ahead, which is by VIP and nitric oxide. This is the peristaltic reflex, and the direction of the peristaltic reflex is always towards the anus, and this is what is called as the law of gut. Okay, this is called as the law of gut. The peristaltic reflex, okay, and the direction that is always towards the anus is the law of gut. So keep in mind that GIT motility is one of the very repeatedly asked questions. So when you consider your GIT, remember there is sympathetics and parasympathetics, out of which Your sympathetics, they are inhibitory to GIT in contrast to heart, and the parasympathetics are stimulatory to GIT. But apart from this, the more important is your enteric nervous system, that is your aorbac plexus. Okay, your aorbac plexus and your Mersner's plexus. Aorbac plexus, which is controlling the motility, and the Mersner's plexus, which is controlling the local secretions and the local blood flow. It is the submucosa. So this is with this question, and this is the related theory. I hope it is clear. Now let's move on. Which of the following is not a molecular motor? Which of the following is not a molecular motor? Options are myosin, actin, dynamin and kinesin. So let me tell you that this molecular motor is something which is also called as a cargo protein. Cargo protein. So which of the following is not a molecular motor? Anybody? Anybody would like to answer this? So the correct answer over here is actin, which is not a molecular motor. So myosin, dynamin, kinesin, and there is something which is also called as dynein. All these come into the category of molecular motor or cargo protein. So what is a cargo protein? Something which can take something on the head and carry forward it. So that is a cargo protein. Now you know that myosin, it helps in muscle contraction, right? Myosin helps in muscle contraction. Dynamin helps in endocytosis. Endocytosis. Whereas, very good Dhruv, this kinesin and dynein, they are important for axonal transport. Very importantly, another thing which you should remember, that myosin is using ATP, dynein and kinesin are also using ATP, but dynamin uses GTP. So this is something important. Now let's look on to this figure and just make ourselves very much clear. See, you can see that this is your kinesin, which is present over here, the molecular structure, and your dynein. So kinesin is required for orthograde, that is antigrade transport. What is antigrade transport? From the neuronal cell body towards the end. Okay, from the neuronal cell body towards the end. Whereas dynein helps in retrograde transport. What is retrograde transport? Retrograde transport is from the end or from the terminal back towards the cell body. So this you must know, that kinesin and dynein and the directions which are important, right? Whereas this is the structure of your ATP, your cargo binding protein, that is your myosin. Next one. Which is true regarding SGLT? This is one of the most repeated questions on glucose transport. You go and you even see your NEET PG questions, you even see your FMG, you will find that glucose transport ke upar there are n number of questions. So what is this? It is a secondary active transport of glucose in brain, in prostate, in intestine, or in the rods and cones. Where is it, boys and girls? What is SGLT? Yes. So the correct answer is C. C. It is not brain. It is C. Very good, Ajju. It is C. Now, when we speak of glucose, this glucose, it shows two type of transport, that is active and passive. Passive is what we called as the various glutes, right? Passive, which we called as the various glutes, which are example of facilitated diffusion, right? They are examples of Facilitated diffusion. Yes, Dhruv, correct. Active includes your SGLT, that is your sodium glucose co-transporter. Now, though we called it as SGLT, okay, though we called it as SGLT, that is the sodium glucose co-transporter, this can carry glucose as well as it can carry galactose, because whenever a carrier is involved, this carrier, it shows saturation kinetics. Okay, the carrier, it shows saturation kinetics, that is TM, the transport maximum. But these also are subjected to competitive inhibition, right? They are also subjected to competitive inhibition. That is one important property. Now you have got SGLT1 and SGLT2. Out of this, SGLT1 is present in the intestine, that is your GIT, and SGLT2 is primarily in the PCT. Yes, correct, Dhruv. Okay. Now this is a very, very important table for you. You can keep this table also for your reference. Right? What does this table say? See, this table reflects simple diffusion. The simple diffusion is passive and downhill, where there is no carrier, no energy and no dependence on sodium gradient. This is very interesting, that there is no dependence on sodium gradient. Facilitated diffusion, passive, downhill, carrier mediated. This is something important, that it is carrier, oh god, it is carrier mediated, right? It is carrier mediated. But again, even if it is carrier mediated, there is no energy needed and there is no dependence on the sodium gradient. No energy needed and no dependence on the sodium gradient. When you consider the primary active, they are uphill, that is against the concentration gradient, right? Yes, it is carrier mediated, uses metabolic energy, but it is not depending upon sodium gradient. It is transporting the sodium outside, so it is not depending upon the sodium gradient. But co-transports and counter-transports, which are example of the secondary type of transports which use energy. Now something very important, see, the active transport is using direct energy, whereas the passive or the co-transports, they are using indirect energy. This becomes a very important MCQ. Direct energy means a direct hydrolysis of ATP, where the sodium gradient is not needed, but a co-transport or a counter-transport, यहाँ पर the energy is used, but it is indirect. It is an indirect usage of energy where it is dependent on the sodium gradient. So this becomes very, very important, table, one important table, and you can go through many MCQs through this. तो इसको अच्छे से, अच्छे से देखो. If you have, you can just take a picture of it, whatever, but keep this table for you. Next one. Enteropeptidase is secreted by stomach, duodenum, jejunum and ileum. Enteropeptidase is secreted by which of the following? So what is enteropeptidase? We will look upon. It is also called as enterokinase. It is also called as enterokinase. Yes, Yashank has given the first answer. Very good. Yes, it is duodenum. Now, what is the need of this? This enterokinase or your enteropeptidase, it is something that is going to convert your trypsinogen into trypsin. Once this trypsin is activated, it is going to bring about the activation of the other enzymes. So this is something very important. How to, remember this, and what is the importance of this? The conversion of the reactions, the conversion of the inactive enzymes to active enzymes is kind of a positive feedback mechanism of GIT. It is the positive feedback mechanism of the GIT. This enterokinase is not present in the pancreas, isn't it? And therefore, you cannot bring about the activation of trypsinogen to trypsin in the pancreas. This what protects auto digestion of the pancreas. This what protects the auto digestion of pancreas. Okay, so that is the advantage, that only when this pancreatic secretion, it will come into the intestine and it will come across this enterokinase, तभी जाके वो activate होगा and it is going to then activate the other enzymes. So that is the most important utility of that. Then the next thing which you should know is that this enterokinase is activated, or its activity is increased, or its secretion is increased by one of the very, very important hormone, that is CCK. So which hormone increases the secretion and activity of enterokinase, which is also called as enteropeptidase, is your cholecystokinin. Got this point? Is the things clear? So can somebody write yes or no so that we can proceed? Is it everything clear? So we can proceed to the next topic, or we can proceed to the next question. Clear ekdam? Very good, Ajju. Thank you. Now, very, very important question. Something very important. Yes. Question says that which of the following is the best stimuli for release of vasopressin? Right? Hypertension, hypotension, hypotonicity of the ECF, or hypoosmolarity of the ECF. Very interesting question and a very conceptual question. Hypertension, hypotension, hypotonicity, or hypoosmolarity. Yes, very good. Raman has given the first correct answer. Good, Raman. Yes. It is hypotension. Now this question becomes very, very tricky. Right? It is very tricky. Now see how. Now there are two things which can increase the release of vasopressin, that is ADH. One is hyperosmolarity. And the other is hypovolemia. So out of this 1 and 2, which of the following is the more important stimulus for the release of ADH? Whether it is hyperosmolarity or whether it is hypovolemia. Who will come up with the correct answer? Hyperosmolarity or hypovolemia? Which of the following is the best stimuli? Yes, Ajju. Ajju said 1. So I give you a star, Ajju. Very good. Hyperosmolarity is more. Both of these are going to increase the release of ADH. But the most important is hyperosmolarity. Most important is hyperosmolarity. Now why? So whenever there is a decrease in the water intake, right? Whenever there is a decrease in the water intake, okay, okay, I'll take it in the other way. Wait, let me teach you like this. 1 minute. Why hyperosmolarity is important? Now in any condition where there is lots of dehydration, suppose you are standing in hot sun, right? You are perspiring, you are exercising. ऐसे सब conditions में there is going to be increase in the plasma osmolarity. Okay, there is going to be increase in the plasma osmolarity, hyperosmolar plasma. This is going to result in the stimulation of the osmoreceptors. It is going to result in the stimulation of the osmoreceptors which are present in the anterior hypothalamus. So there is going to be the firing of the osmoreceptors which will be from the anterior hypothalamus. This osmoreceptors, they actually undergo shrinkage. Because of dehydration, they undergo shrinkage, and this also causes stimulation of two areas. One is the supraoptic nucleus of the hypothalamus, and the second is the stimulation of the lateral hypothalamus. This supraoptic will increase the release of ADH, and the lateral hypothalamus is the drinking and the feeding center, and the person will drink. So as you stimulate both the areas, that is the drinking center as well as the ADH release center, you are going to drink water, and at the same time the kidneys will conserve water. Okay, it will conserve water because you are secreting ADH. Therefore osmolarity is the most important factor, right? Whenever there is going to be a decrease in the plasma osmolarity, reverse will happen. There will be inhibition of the osmoreceptors, there will be a decrease in the release of ADH. Yashank, sweating is both. You have ekdam correctly said. What happens when you are sweating? When you are sweating, there is a loss of hypotonic fluid. Since you are losing hypotonic fluid, the salts are getting retained in the plasma, and these salts which are getting retained in the plasma is increasing plasma osmolarity. समझा क्या बेटा? समझा? Did you understand? Yes. Now, so the most important stimuli is your hyperosmolarity. Now, reverse will occur. Remember that, this release of ADH, okay, the release of ADH and the renin, angiotensin, aldosterone mechanisms. These mechanisms are basically the mechanisms which are activated in compensatory cases. So a decrease in the ECF volume, right? A decrease in the ECF volume, or a decrease in the blood pressure. For example, you are standing for a long time, you are exercising. All these conditions are going to be very, very important stimuli to increase the release of ADH. Now, when ADH is acting, ADH is also called as vasopressin. Why? Because it can cause a smooth muscle contraction. Because it can cause the smooth muscle contraction. That is the other function. But there are different receptors which are present. So when ADH causes an increase in the water permeability in the principal cells of the late distal tubules and the collecting ducts, the receptor which it is using is V2, which is coupled to adenyl cyclase via GS, that is stimulatory G protein, and here you are using cyclic AMP as the second messenger. Okay, you are using cyclic AMP as the second messenger. But when it causes contraction of the vascular smooth muscle, it is acting through V1 receptors, where you are using phospholipase C and GQ protein. So here the second messenger is going to be calcium. So the second messenger is going to change depending upon the receptor, depending upon the V1, V2 receptor and the mode of action. Remember, in general, whenever there is metabolism going on, जब भी कोई metabolism होता है, That metabolism, whether it is water metabolism, it is mineral metabolism, it is lipolysis, it is glycogenolysis, the mediator is cyclic AMP. And whenever there is contraction, whenever there is exocytosis, at that time the messenger which is used is calcium. This is a kind of a hard and fast rule in general. Okay, next one. Electrical impulses originate in the options: SA node, AV node, endocardium or epicardium. Yes, very good, without any doubt, isn't it? Without any doubt, what we have is, 1 minute, SA node. Okay, so 1 minute. Yes. Now, why did I take this answer? Is there are a number of questions which come on SA node. So remember that the cardiac muscles, okay, they have got automatic fibers which are atria and ventricles, which are responsible for the heart muscle contraction, right? They are responsible for the heart muscle contraction. That means you're going to pump the blood, right? And they are contractile, they are having the property of generating force of contraction, especially the ventricles. But there are, fibers which are conducting tissues. Okay, these are the fibers which are conducting tissues. These conducting tissues are specialized cardiac muscle fibers. They are specialized cardiac muscle fibers. They do not generate the force of contraction, but they are responsible for the automaticity, right? They are responsible for the automaticity. This SA node is present in the superolateral wall of the right atrium, just below and lateral to the opening of the superior vena cava. This comes as MCQ. And AV node is present in the posterior and the inferior part of the interatrial septum. So the location comes as MCQ. Now, this is a very important table where you are shown the conduction of the cardiac impulse that begins from the SA node, AV node, bundle branches, Purkinje fibers, epicardial and endocardial surfaces. There is a very important MCQ on AV nodal delay, that is around 0.13 second, and AV node is called as the gatekeeper of heart. Remember, when we speak of heart, the depolarization is from the epicardium to the endocardium. Okay, but the repolarization does not follow the same direction. This will take in the another MCQ. Okay, this will cover in another MCQ. Focus on AV node, which is called as the gatekeeper of the heart, or the AV nodal delay, which allows the atria to completely empty its content into the ventricles before the ventricles start contracting. The AV nodal delay is reflected as the PR segment. It is reflected as the PR segment in ECG. Okay, it is reflected as the PR segment. देखो, segment is going to differ from interval. Segment is an isoelectric period where there is no electrical activity going on in the heart. That is a segment. So don't confuse the segment with interval, right? Next, inhibin is secreted by Leydig cells, Sertoli cells, interstitial cells, or the PEG cells. Inhibin is secreted by which cells, and what is the role of inhibin? Very good, Abdul. So Abdul has given the first correct answer. Very good. So it is by the Sertoli cells. So first, before we move forward, let us look into the functions of the Sertoli cells. The Sertoli cells, first important function, they secrete inhibin. Second is that they form the blood testis barrier. Okay, they form the blood testis barrier. They secrete androgen binding protein. They secrete androgen binding protein, and this androgen binding protein binds to testosterone. Okay, it binds to testosterone and it enables the high concentration of testosterone near the area where we are going to have the sperm production. So even if you know the testosterone level, if it is more in the blood and if it is not near the Sertoli cells, it is not going to be of use. You should have a high concentration of testosterone near the seminiferous tubules, only then there can be spermatogenesis. So that is the most important property. Third important, it secretes Mullerian inhibiting substance. This Mullerian inhibiting substance is going to suppress the Mullerian ducts, right? It is going to suppress the Mullerian ducts, and by suppression of the Mullerian ducts, you bring about the growth and development of the Wolffian ducts, so that the developing fetus will be a baba or a boy, right? The developing fetus will be a baba or a boy, because you have to suppress the Mullerian. So that is very important function of the Sertoli cells. Now, this is a very, very important table taken from all standard books. So you never think that ma'am is taking anything from not good sources. I'm always taking the things from good sources so that you can rely upon them. Now there is something which is called as GnRH, that is the growth hormone, the gonadotropin releasing hormone, which is coming from hypothalamus, and this comes as MCQ, that it is coming from the arcuate nucleus of hypothalamus. Okay? It is coming from the arcuate nucleus of hypothalamus. Now the secretion of the GnRH should be pulsatile. If there is a continuous secretion of GnRH, or if you are giving a continuous infusion of GnRH, you will see that there can be suppression of the fertility, because the pulsatile secretion is going to act upon the anterior pituitary to increase the secretion of FSH and LH. The LH is coming from the Leydig, the LH is stimulating the Leydig cells, LL, okay, LL. The LH is stimulating the Leydig cells which secrete testosterone, and the FSH is acting on the Sertoli cells which secrete inhibin. So why are we studying this? We are studying this because we should know that LH, okay, LH, which is increasing the testosterone, is controlled by testosterone. So testosterone is going to inhibit LH, whereas FSH is inhibited by inhibin. Okay, FSH is inhibited by inhibin. Therefore we have studied the whole story about this. Next one. What is the center controlling vomiting? What is the center controlling vomiting? And the options are apneustic, hypothalamus, area postrema, or pneumotaxic. Very good. Yes, Abdul has come first. Very good. So it is definitely area postrema. So you must know that there are certain areas in the brain which are outside the blood-brain barrier. For example, your area postrema, right? Yes. Yes. Then you have got the the median eminence of hypothalamus, where there is presence of the satiety center. Satiety center. You have got posterior pituitary outside the blood-brain barrier, and another important organ, that is OVLT and SFO, that is organum vasculosum of lamina terminalis. Organum vasculosum of lamina terminalis, and SFO is the subfornical organ. Now what is the importance of this? OVLT and SFO. These are the centers which are stimulated by angiotensin 2, and they are supposed to be your thirst centers outside the blood-brain barrier. So inside the hypothalamus, you have got the thirst center, that is your lateral hypothalamus, isn't it? But angiotensin 2 can stimulate thirst, which is called as volumetric thirst, when the blood volume decreases. That is by stimulating these areas, right? And remember that this satiety center, you know that it inhibits the feeding center, and then the person is going to stop eating. This satiety center needs glucose. So whenever we are eating, the blood glucose level will rise, the glucose will enter the satiety center, which will inhibit the feeding center. Now the entry of glucose into the satiety center is insulin dependent. Okay, it is insulin dependent. So because it is insulin dependent, what happens? In patient with diabetes, the patient feels polyphagia, isn't it? So what is the reason of that polyphagia? Obviously there is a deranged metabolism, but another important reason is that the satiety center is not getting activated because it needs insulin for the glucose uptake, and because insulin is not present, the satiety center is not receiving glucose and it is not able to inhibit the feeding center, resulting in polyphagia in a patient with diabetes. Next one. Prothrombin to thrombin conversion needs calcium, magnesium, potassium, sodium. Clotting mechanism is a mechanism which is repeatedly asked in the exam. बहुत बार आपको clotting पर question आता है. So what is required? Definitely Abdul is correct. It is the calcium which is needed. Now see, this is the basic mechanism of clotting, which is going to be common to both intrinsic and extrinsic pathway. This is the basic or the final common pathway. What is that? Yes, Ajju, correct. There is prothrombin. Okay, sorry. This is the prothrombin, which requires a prothrombin activator, and it gets converted to thrombin. This thrombin is going to convert the fibrinogen to the fibrogen monomers. Ultimately, the fibrin fibers are converted to cross-linked fibrin fibers, which require factor number 13, that is your fibrin stabilizing factor. Okay, your fibrin stabilizing factor, that is factor number 13. This factor is very important to provide the strength to the clot. You have to convert the monomers or the fibrogen fibers into cross-linked fibers. If you are not converting them to cross-linked, they cannot function effectively as a clot. Now platelets का जब हम function पढ़ते हैं, when you look into the function of the platelets, these platelets are very important for the clot formation. They actually stop bleeding, which we called as hemostasis. See, it is not homeostasis, it is hemostasis. So there are platelets which form the clot, which are important for hemostasis. But another very important function of the platelet is the clot retraction. Very important. If the clots are not retracted, they cannot occlude or they cannot seal the broken blood vessel. So one of the very important function of the platelet, apart from the clot formation, is clot retraction. Next one. What cardiac event occurs at the end of the isovolumetric relaxation? At the end of the isovolumetric relaxation. AV valves open, AV valves close, corresponds to T wave or corresponds to C wave. Yes, Raman has come with the correct answer. Good. Very good. opening of the AV valves. Now, there was a question which was given to you in your exams this time. Now, suppose this was an image based diagram. Suppose I'm drawing this image over here and I'm making it 4 points, A, B, C and D. On x-axis is the left ventricular volume, and on y-axis is the left ventricular pressure. And suppose the question says what event is taking place at point B. At point B, mitral valve open, mitral valve close, aortic valve open or aortic valve close. At point B, what is taking place here at point B? A, B, C, D. So this was an image based question which was given to you. Or I can put this question in another form. I can say you, where is S1? Yes, Abdul is correct. It is this. That is closure of the AV valves at this point, resulting in the first heart sound. Now let's try to analyze this question or understand this question. Okay. Now, this is the LV loop. Why this is LV loop? Because on the x-axis there is left ventricular volume and on the y-axis there is left ventricular pressure. This is point A, point B, point C and point D. Now, suppose this is your segment 1, okay? This is your segment 1, which is period of filling. That means the blood is passing from the atria to the ventricles, diastole of the ventricles. Yes. So this diastole comes to an end as the pressure rises. Okay. So as the pressure rises, the diastole comes to an end. And there is closure of the mitral valve, because we are speaking of the left ventricle. There will be closure of the atrioventricular valves, but we are speaking of the left ventricle. So there is AV valve, mitral valve ka closer and S1. So S1 is coming at this point. The phase 2 is isovolumetric contraction. So as the ventricles, they get filled up with blood, the valves close, and the ventricles, they get converted into closed chambers and the pressure rises. Now when the left ventricular pressure will become more than the pressure of the aorta, there will be opening of the aortic valve. So point C is going to be the point where there is opening of the aortic valve, and as the aortic valve opens, there is an end of isovolumetric contraction. After contraction, there is always ejection. There is always ejection. जैसे contraction होगा मतलब systole, तो systole का second part will be ejection. So ये जो है segment 3 or from C to D is giving us an idea of the stroke volume. It is giving us an idea of the stroke volume, that is volume of blood that is pumped by the ventricle per beat. Now as the blood gets ejected, the volume decreases, the pressure decreases, and there is closure of the aortic valve. So this is the point where there will be S2. What is S2? Second heart sound. What is the cause? Closure of the semilunar valves, and we are speaking of the left ventricle, so this is going to be the aortic valve, and the aortic valve remains closed till there is isovolumetric relaxation. The isovolumetric relaxation means the ventricles are having very less amount of volume. So this volume on the extreme left, 50, is the end systolic volume, and the volume on the extreme right is the end diastolic volume. Okay, it is the end diastolic volume. So you can calculate stroke volume as end diastolic volume minus end systolic volume. ठीक है, तो यहाँ पर कितना है? It is 130 minus 50. It is 130 minus 50, that is 80 ml. And suppose you are asked to calculate the ejection fraction. It is stroke volume upon end diastolic volume into 100, that is 80 upon 130 into 100, which will come around 60%. So this comes even as a calculation based question. It is a very important, LV loop is very important for you to understand. So this you should keep in mind, that the same thing can also come in the form of image based question. It can come in the form of a calculation based question, right? Is it clear, bachcho? Is it clear? The LV loop and in brief the cardiac cycle, because you have to now correlate the things. It is not possible that you will be learning everything. अभी आपको सब correlate करना पड़ेगा. समझ में आया? Yes, clear? Yes, good. Now, adrenal medulla secretes sex hormones, epinephrine, TSH or glucocorticoids. Now the question seems to be very simple, but we made blunders in this also. What does medulla secrete? Very good, Ajju has given the correct answer. सबसे पहले दिया, so a chocolate. Very good. It is epinephrine. Now, when we speak of the adrenal gland, there is cortex, there is medulla. Cortex has 3 layers: granulosa, fasciculata and reticularis. Fasciculata is maximum 50%. This is around 21% and this is around 7 to 8%. Fasciculata secretes basically glucocorticoids. This is secreting aldosterone, that is mineralocorticoids. Reticularis, it secretes the androgens. It does not secrete testosterone. So even college में भी जब मैं पढ़ाती हूँ या जब मैं एग्जाम ले रही हूँ, जब मैं वाइवा ले रही हूँ, तो बच्चे बोलते हैं testosterone. That is a wrong answer. It secretes androstenedione and dehydroepiandrosterone. It secretes dehydroepiandrosterone and androstenedione. Adrenal medulla secretes epinephrine and norepinephrine, which we also called as adrenaline and noradrenaline. Remember, this is around 80% and this is around 15 to 20%. So the maximum secretion from the adrenal medulla is epinephrine. Epinephrine is a pure hormone. It is a hormone. Norepinephrine is a hormone, but it is also a neurotransmitter because it is also secreted from the sympathetic nerve endings. It is also secreted from the sympathetic nerve endings. There are small things which we underestimate and which we don't realize the importance, and we make silly mistakes. So norepinephrine is a neurotransmitter plus hormone, but epinephrine is only a hormone. Adrenal cortex में the largest area is for fasciculata, and the androgens are dehydroepiandrosterone and androstenedione. Another MCQ which is related to this is that in females, these adrenal androgens are very important. What is the role? So in females, the maximum growth, the development of the body, the fat deposition, the skin, the breast, and the genital organs, they are all taken care by the estrogens and the progesterones. But the pubic and the axillary hairs, the pubic and the axillary hairs, they are only brought about in females by adrenal androgens. That is the most important function in females. अपार्ट फ्रॉम दिस एक और बात याद रखो कि जब प्यूबर्टी होती है, ठीक है, व्हेन देयर इज प्यूबर्टी देयर इज secretion of GnRH. It is required, isn't it? And there's going to be menarche, right? There are going to be the changes in the males and the females. They're going to be increase in the hypothalamic pituitary gonadal axis. उसी समय पर एक important जो होता है is adrenarche. So adrenarche is one of the important thing which may just precede or it may just come along pubarche. ठीक है, तो जैसे प्यूबार्की होने वाला होता है जस्ट उसके पहले या उसके साथ में there is also going to be adrenarche which is going to bring about the release of the adrenal androgens which contribute. So when we speak to puberty, there is GnRH from the arcuate nucleus, there is LH and FSH. Never forget the permissive role of something which is called as leptin. Leptin is very, very important, and therefore a small amount of the body fat is needed for the puberty to occur, because that fat mass secretes leptin, which increases the sensitivity of the peripheral tissues or the target tissues to GnRH. There is something very interesting at the edge I am telling you, which is called as kisspeptin, and there is a role of kisspeptin hypothalamic neurons which also contribute to puberty, right? Next, renin is coming from where? Juxtaglomerular cells, tubular cells, macula densa cells, or all of them can secrete renin. renin कौन बना रहा है? अच्छा, अज्जू मैं तुम्हें बताती हूँ, ये जो अज्जू लिसन बेटा, जो ये लेप्टिन होता है ना, इट इज गोइंग टू यूज एंजाइम linked mechanism. Enzyme linked mechanism. There are group of enzymes which are the tyrosine kinase receptors. The tyrosine kinase receptors, which is used by growth hormones, which is used by insulin. उसमें उस टाइप के mechanism में there is use of leptin. Got it? Yes. वही वाला था. जैक स्टैट जो है ना अज्जू, वो बेटा इसके लिए है, ग्रोथ हार्मोन और प्रोलैक्टिन के लिए, जैनस काइनेज जो हम बोलते हैं, जैक स्टैट. ठीक है, यस, जयदीप मोहम्मद हैज गिवन द करेक्ट आंसर. द juxtaglomerular cells are also called as the granular cells. Now, yes, so juxtaglomerular cells has got the following important cells. It has got renin secreting cells, which are the juxtaglomerular cells. Now, where are they coming from? So first important cell, these are the granular cells or the juxtaglomerular cells, which are actually coming from the afferent arterioles. That means they are modified smooth muscle cells. They are modified smooth muscle cells. Because they are smooth muscle cells, they can contract, they can relax. That means whenever the blood pressure rises, there will be stretching of the granular cells, right? So they are just behaving like baroreceptors. अच्छा, रमन ने फर्स्ट दिया था क्या? ओ सॉरी, रमन ने फर्स्ट आंसर दिया था. सो रमन को क्या करते हैं, रमन को 2 चॉकलेट्स देते हैं, 1 फॉर रेक्टिफाइंग माई मिस्टेक ऑल्सो. यस, This is something cute happening in the class. So I gave you extra chocolates for the correct answer and for rectifying my mistake also. Okay, good. This shows that you are guys are interactive in the class and you are really, with me. Even though not, I cannot see you, but yes, I can feel you. You are with me. So these are the granular cells which are coming from the smooth muscle cells, which are modified afferent arteriole cells. So I told you that they are subjected to stretch. Then the second one are the macula densa cells. So D yaad rakho, these are coming from DCT, and they are the cells which actually behave as the chemoreceptors, Yes, I should, for chocolate, for asking question, I'll give you a cup of tea. Cup of tea means you are totally energetic, your centers of the brain are really active, and therefore I would like to give you a cup of tea for the questions which is asked, which again is a sign that the bachas are totally interactive. Yes. And finally, there are lassus cells, which are actually your plugging device. Okay, they are actually your plugging device. Now, one of the very important thing, I'll just put on a question to you is that which of the following is not a component of juxtaglomerular apparatus? A, it is granular cells. B, it is macula densa cells. C, it is extraglomerular mesangial cells. It is extraglomerular mesangial cells, or D, stellate cells. So which of the following is not a component of juxtaglomerular apparatus? Yes, Faisal and Tarun. Bolo. Now, this is very important. Granular cells are same as the juxtaglomerular cells, which is not a component. Which is not a component. Macula densa cells, yes. Extraglomerular mesangial cells are same as the lassus cells. The stellate cells are intraglomerular mesangial cells. That means they are present between the basement membrane. And the capillary endothelial cells. These cells are contractile in nature. Okay, these cells are contractile in nature. That is, they can decrease or increase the GFR by affecting the kinking of the capillaries. This comes as repeated MCQ even with the NEET PG. So the intraglomerular mesangial cells, which are also called as the stellate cells, are not a part of the juxtaglomerular apparatus. Right? So juxtaglomerular cells, they are smooth muscle cells modified which secrete renin. Macula densa cell, they are coming from DCT, which are going to sense NaCl, and they also behave as sensors of the tubuloglomerular feedback mechanism. They behave as sensors of the tubuloglomerular feedback mechanism. This mechanism plays a very, very important role in maintaining GFR. Good evening, Akshay. Good evening, beta. God bless you. Good evening. Yes. So, juxtaglomerular apparatus is one of the very, very important question. Remember that renin. Okay, what is renin? Renin is basically a enzyme that is mainly going to be secreted whenever there is compensatory conditions. So whenever there is a decrease in blood pressure, right, or whenever there is sympathetic stimulation, prostaglandins, decrease in NaCl, all these conditions are going to bring about the secretion of renin. But when the blood pressure is already high, right, when there is already high blood pressure, when already there is hypervolemia, or you have increased the GFR and you are increasing the delivery of NaCl to macula densa, these conditions will decrease the secretion of renin. So renin per se is very, very important. And another very important silly mistake which we performed: who secretes erythropoietin? So erythropoietin is not coming from the juxtaglomerular apparatus. This is one of the most common mistake we do. Erythropoietin is coming from the interstitial cells of the peritubular capillaries. Interstitial cells of peritubular capillaries. So ये भी एक common mistake है. Erythropoietin is not from the juxtaglomerular apparatus. So I think enough for today. I'm going to continue this as a second session very soon, maybe this weekend or next week. So till then, remain tuned, remain interactive, make a good timetable, and please ensure that you always give some time to calm down your mind, because if you don't calm down your mind, you are not prepared for the race that is next day. So be planned, be optimistic, and always look on the brighter side. Have a feeling of gratitude. Always feel blessed for the blessings you have in your life. You are educated, and at the end of the day, you are definitely going to be something. It is never that iske baad, uske baad, iske baad. At the end of the day, you are going to be something, because everybody is destined to become something. So never give hopes. Just keep on studying and give your best. And always take time to relax, rejuvenate your mind. So we meet you very soon with the second session of this MCQ with theory. God bless you all. Thank you, and lots of love and blessings.